Good afternoon, everyone. I would like to welcome you to today's presentation featuring Dr. Carolyn Ross. There's a few things to note. Participants will be muted upon entry and videos turned off. We'll ask for any technical assistance questions that you use the chat feature located at the bottom of your box. You will also receive an email approximately 1 month from today requesting feedback and impact on today's presentation. Also, we ask that you visit www.ncdus.org/training to view other training opportunities from NCED. This training will be recorded and placed on our training site 2 weeks from today. Slides and an evaluation will be sent to you immediately following the webinar. We will also have 10 minutes allotted for question and answer at the end of this segment. Any unanswered questions will be sent to you with responses via email 1 week from today. I'll now go ahead and introduce today's speaker, Dr. Carolyn Ross. Dr. Carolyn Coker Ross is an African-American author, speaker, expert, the treatment of eating disorders, trauma, and addictions. Dr. Ross is a graduate of the University of Michigan Medical School. She completed a residency in preventative medicine and a master's in public health at Loma Linda University and a fellowship in integrative medicine at the University of Arizona. She is board certified in preventive medicine and addiction medicine. Dr. Ross has been an international speaker and consultant on issues of mental health, trauma, workplace productivity, and intergenerational trauma. Dr. Ross presented a TEDx Pleasant Grove talk on historical and intergenerational trauma in January 2020. She is co-founder of the Institute for Anti-Racism and Equity, a consulting group that offers DEI trainings to organizations on diversity, anti-racism, and equity in the workplace. I'll now turn things over to Dr. Carolyn Ross.
Thank you, Lachelle. It's great to be with you all. So let's get started. So today I'll be talking with you about shared cofactors for substance use disorders and eating disorders. I think this is an important topic because anybody in the field who works with either of these disorders knows very well that often you will treat the substance use disorder and then all of a sudden the eating disorder will pop up and vice versa. So it's good to understand what are the co-occurring underlying factors that promote this relationship between the two. So here are the objectives. Here is my extensive bio for your nighttime reading. And I'm going to start by just talking about the neurobiology of trauma, because it's important to understand that trauma is not just, what happens to us and how we react. That probably the most important thing to understand about trauma is its impact on brain development, especially in children. So Bruce Perry, who's a well-known child psychiatrist and trauma expert, talks about the fact that the brain has plasticity. That basically means that our brains can change, but this is most available when we're young. And I want to just draw your attention to the part in red where he says trauma, neglect, and other experiences of maltreatment, including prenatal experiences like exposure to drugs or alcohol, or impaired attachment or early bonding, all influence the human brain. So just briefly, I don't want to bore you with a lot of detail, but there's a couple of things that I think would help you to know. First of all, brain development is bottom up. What does that mean? Well, when you're born, the things that the brain is developed enough to secure your survival. So this part of the brain, the reptilian brain, is the survival center. It's where the fight, flight, or freeze response comes from. And it is completely developed at birth, and that helps with breathing, digestion, heart rate, sleep, hunger, any instinctual behaviors, and any behaviors that sustain life. So when the baby is born, they're born with a brain that helps them to survive. And then from birth to age 5, the emotional or limbic system in the brain is developed. And this is the part of the brain that processes emotions, memory, response to stress, nurturing, caring, separation, anxiety, fear, rage, social bonding, and hormone control. And then finally, the last part to develop, as we know, is the executive center, or the thinking part of the brain, called the prefrontal cortex. And this can develop in fits and starts between 5 and 6, 11 and 15, all the way into the early 20s. And this is the part of the brain that helps us think logically, have empathy and compassion, creativity, be able to self-regulate our emotions and behaviors. It also includes self-awareness, predicting, planning, problem solving, and attention. So if you think about this and you think about the timing of any kind of maltreatment, child maltreatment, you can see that timing really is everything when it comes to the brain development. So if a child experiences adverse experiences between the ages of 0 and 5, that will definitely affect their emotional capacity. They may find themselves in fight, flight. They may experience a lot of outbursts, in problems with impulse control, problems with bonding or attachment, and so on. If, however, it occurs after that time, then we're looking at people who may have attentional issues like ADD, ADHD, have trouble regulating themselves, have a lack of self-awareness, and so on. So brain development is bottom up, and all of it works together. So this sequence has to go together. And then the next fact is timing is everything. So I think this is something that we don't really think about clinically, but we see this in our patients all the time. I remember in some of our, when I worked in a treatment center, we would talk about how some of the patients had the emotional regulation skills of a toddler, for example. And that's true, because if they were harmed before the age of 5, they don't know how to regulate themselves. So let's keep that in mind as we go through and talk about trauma and substance use disorders and eating disorders.
Dr. Ross, I hate to interrupt you before you go to the next slide. Is it possible for you to put the closed caption on some folks on that are asking at the bottom of your screen, the closed caption?
Okay.
You see where it says CC?
Oh, right.
Yeah,
Okay.
yeah, perfect. Thank you.
And what does that do, actually?
For anybody that may be hearing impaired.
Oh, gotcha.
Yes.
Now I see it. Well, it says subtitles aren't available. I'd have to restart everything.
Oh.
I mean, do you want me to do that, or I'd have to restart the whole PowerPoint and everything? I don't know how to go through and do that.
To do it from the beginning, yeah. I think we might have to restart it and then get to your current slide. Let's see if that works.
It's asking me to do permissions, and that's the part I'm not sure.
About.
Could you do it in the transcript? Do you give a transcript of the
Yeah,
talk?
we do give a transcript at the end.
So can't they view it with the transcript then? I can try it, but I don't want to lose all of my time either.
Yeah, I understand. I apologize too. I guess all we can do is try. I guess I'll let you go ahead and try it, and it's the option. Okay, somebody just said, let me see, it's the option at the bottom of the form. So anyone can enable it by using the options at the bottom.
I didn't hear what you said.
Someone just wrote in that Zoom allows it if you use the options at the bottom of the bar. It allows a closed captioning for anyone that needs it.
Well, that's what we clicked on, and then it said
Yeah, it's
restart.
so I guess I'll let you just restart it and get to your current slide, and then we'll see what it does there. If not, then we'll have to see how to reprogram this in the future. I'm not sure what happened. But we do have a transcript that would be available with the slides at the end of the presentation for everyone that's on. So you can go ahead and just try to get back to your current slide with this closed caption on, Dr. Ross. I apologize.
Yeah, I was just trying to see where I could give the permissions, but I'm not sure I know how to do that. I'd have to figure it out.
Okay.
Yeah, it's not easy to
It's
see.
not allowing you to.
Yeah, I'd have to figure it out. I don't know how to
Okay.
do it. So I'm sorry about that, but
No,
next time.
that's fine. I
Yeah.
definitely understand.
Okay, so let's get back to where we were. All right, so we're talking about the development of the brain. So often when we talk about eating disorders and substance use disorders, we also talk about the reward center, the dopamine reward center of the brain. And that part of the brain is where the pleasure happens, where we get reward for, eating, playing with our kids, petting a dog, watching a sunset, but also using drugs or food. And this part of the brain has two functions. It works with judgment, thinking, and executive function in the prefrontal cortex, which I told you is the last part of the brain to develop. And it works on the limbic part, where there's emotion, memory, and impulsivity. So obviously, trauma that occurs before the development of the prefrontal cortex would affect judgment, thinking, and executive function. And we know that most eating disorders and substance use disorders start before the development of the prefrontal cortex. So as I said, the child's brain has plasticity more than an adult brain. And this applies to good or quote unquote bad experiences. I'll show you in a little bit, but more on this. But it's important to recognize, especially for parents, that if you protect your child from every experience that they can possibly have, you are harming them, because then their brain doesn't develop the ability to self-regulate, to regulate emotions, to be able to think through things and have judgment and so on. So we need to expose children to good and not so good experiences. And the way to do that is to always have adult supervision and support when bad experiences happen. And the timing of adverse childhood experiences does make a difference. The biggest impact of child maltreatment is children who are maltreated under the age of 3, but we go all the way up to age 18 as having a big impact. I wanted to just finish with this last one. So neglect also affects a child's brain. For example, a 10-year-old child may have the speech and language skills of an 8-year-old, the social skills of a 4-year-old, and the emotional regulation skills of a toddler. And I think that's something, if you think about it, you see in your patients, especially if you're working in a residential or PHP type facility. So when there is a threat to the child that is prolonged and repetitive, and there isn't enough adult supervision or support, the brain then goes into certain changes. It changes the brain's response to stress in particular, and the response to stress may become what we call hyperactive. And the brain then will reset, acting as if it is under constant and present threat, even when the threat is no longer there. So I just want you to think about that for a moment. And you see a patient who may overreact or have impulsive outburst or emotionally dysregulated, and there is no threat around them. It's because their brain has altered, and the brain perceives that it's still under threat even when there is no threat. These are just some statistics to kind of just emphasize the fact that it's not just the United States that has high levels of child maltreatment. It's pretty much across the world. And it's all sorts of maltreatment, whether it be physical abuse, psychological abuse, sexual abuse. And it also applies to armed conflict, like we're seeing the war in Ukraine. And I'm sure there will be a lot of fallout there with pregnant women who, carrying babies during this stressful time that may have an impact on their children. And also refugee settings. We saw a lot of this at the border, at the Mexican border, with immigrants who were separated from their children. That's going to definitely have long-term consequences for the children. And again, child maltreatment is a global issue that affects psychological functioning, mental health, health risk behaviors, life expectancy, healthcare cost, and social functioning. But the most important thing is it hijacks a child's potential in life. And it's not just a phenomena of the West, it is global. And treatment and later prevention are much more costly than treatment and later prevention are more costly than primary prevention. So I'm sure you all are familiar with the ACE pyramid. The only definition for trauma that has been widely accepted is the one from SAMHSA. And SAMHSA says trauma refers to experiences that cause intense physical and psychological stress reactions. Trauma results from an event or a series of events, set of circumstances that are experienced by an individual as physically or emotionally harmful, threatening, and that have lasting effects on the individual's functioning and physical, social, emotional, and spiritual well-being. So just to emphasize, the CDC is now studying trauma from conception to death. So they're looking at the effects of trauma in utero. They're also studying historical and intergenerational trauma and looking at things like poverty, lack of opportunity, community violence, and all of that, social conditions and local contexts that also are considered traumatic to children growing up. And the adverse childhood experiences that they've been studying for some time, I think most of you know, but having a parent with a mental illness, a parent with a substance use disorder, physical, emotional, or sexual abuse, physical or emotional neglect, divorce or separation, witnessing domestic violence, having a family member incarcerated, and a family member with a mental illness. So if you think of that, then these adverse childhood experiences, as I said, disrupt brain development. And this leads then to social, emotional, and cognitive impairment, then the adoption of health risk behaviors, and then chronic disease, disability, social problems. And if there are enough ACEs, it can take 20 years off of the lifespan. So if you have not explored your own individual trauma, you can use this QR code, just taking a picture with your iPhone or your smartphone, and it will take you directly to the ACE quiz. And if that doesn't work, you can also use this URL here, bit.ly/ACE for me, to access the ACE quiz. And I'll give you a few minutes to do that and to see if you can look at your ACE score. And just want to mention that now they're adding another question to the ACE quiz, which is, to the best of your knowledge, have you or your child ever been treated or judged unfairly because of his or her race or ethnic group? So again, the CDC is broadening this study to also include racialized trauma, because we know that that is a daily experience for many children from BIPOC communities. So just give you a couple more minutes to do the questions there and add up your ACE score. And the ACE score is cumulative. So if you have one ACE compared to someone who has 4 ACEs, the person with 4 or more ACEs have much higher risk for all the things that are associated with adverse childhood experiences. Okay, I'm going to move on. And just want to talk a little bit about childhood neglect, which is actually the most frequent form of child maltreatment. And neglect incorporates that notion of that, brain development requires a certain timing, a certain exposure, frequency of exposures and experiences that will help develop the brain cells and brain connections. And that without that, it can minimize a person's potential in life and their ability to self-regulate, speech, language, capacity for healthy relationships, and so on. So if you look worldwide, these are the most commonly reported traumas across the world. Death of a loved one, witnessing violence, or experiencing interpersonal violence. We know that assaultive violence is much more common in the United States than in other countries, as is gun violence. But any kind of trauma related to automobile accidents, natural disasters are pretty similar throughout developed countries. And then the little graph here shows you about 36% of the US population have no adverse childhood experiences. 25% have 1, and so on. But overall, 1 in 5 have 4 or more ACEs, and 63% of Americans have at least 1 ACE. So when we look at adverse childhood experiences, as I mentioned, you can break them down into these 3 categories. I gave you the list just a moment ago. And I also said people with higher levels of ACEs can lose 20 years off of their lifespan. If you have 4 or more ACEs, you're 3 times the risk of developing lung disease and smoking, 14 times the number of suicide attempts, 4.5 times more likely to develop depression, 2 times more likely to develop liver disease, 4 times more likely to have early intercourse, 11 times more likely to abuse intravenous drugs. And the president of the American Academy of Pediatrics has said that adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. So this slide, it just kind of re-emphasizes the importance of exposure to experiences for children's brains to develop. When you have a case of you can see on the left the brain of a normal child, and then on the right is the brain of a child who was in an orphanage where they were not given regular stimulation. They were left, pretty much in their cribs all day while they were fed and their diapers were changed. There wasn't a lot of other interaction or bonding. And you can see the devastating effect it has just on the size of the brain. And in this study, which is a SPECT scan, a PET scan, on the left, you see the circled areas of the brain, which red is the most active, yellow is next, and purple and black are least active. So in this normal scan of a normal child, you see these high red and then low blue and black areas of activity. And as I mentioned at birth, only the primitive structures such as the brainstem, which are in the center, are fully functional. In regions like the temporal lobes, early childhood experience helps to develop the brain, to wire the circuits of the brain. So this is what a child's brain should look like. On the right-hand side, it's the PET scan of a Romanian orphan who was institutionalized right after birth and shows the effect of extreme deprivation in infancy. So here, the temporal lobes, which regulate emotions, get input from our senses, are almost blank. They're quiet. They aren't showing any activity. And these children suffer from severe emotional and cognitive problems. And I know, maybe some of you know, but the adoption of Romanian orphans was pretty popular back in, I don't know, the early 2000s, the late 90s. And many of my patients who adopted these children were having brought home children that on the surface looked very healthy, but their emotional regulation skills were just non-existent. They would act out. They often were very rageful. They didn't know how to discipline them, etc. So it became a real problem. So Bessel van der Kolk says that the impact of trauma is on the survival or animal part of the brain, the reptilian brain, as we mentioned, and that means that our automatic danger signals are disturbed and we become hyperactive or hypoactive or aroused or numbed out. We become like frightened animals. We cannot reason ourselves out of being frightened or upset. Of course, talking therapy can be helpful in acknowledging the reality of what's happened and how it's affected you, but it doesn't help you really put it behind you because it doesn't go deep enough into the survival brain. Now, I had a complaint or a comment when I mentioned something similar to this in the previous talk. And I just want to say, he's not saying that talk therapy is useless. He's saying that it needs to be combined with specific trauma therapies that really access this deeper reptilian brain, the emotional parts of the brain. Okay, there are some triggering images here. So if you're concerned about that, you might want to skip the video.
One of the outcomes of childhood distress is addiction. So that if you look at the research literature on addiction, the more adversity you've experienced in your childhood, the greater the risk of addiction exponentially. And in the downtown east side, Vancouver, which is a population very much affected by addiction, in 14 years, I never met a single woman who had not been sexually abused as a child. And many of the men have been abused, traumatized, abandoned, neglected. Terrible things happen to them over time. Now, addictions are not the problem, at least, of course, they are a problem, but they're also the attempt to solve a problem. And the problem is unbearable psychic distress or pain. So there's no understanding of addiction without understanding human pain. And there's no understanding of human pain without understanding human childhood experience. So it all goes back to that. And that's for two reasons. One is that it instills the pain that you try and soothe with the drugs. And not just the drugs, also with addictive behaviors of all kinds, from shopping to eating to work to internet to pornography to gambling, video games, whatever you're addicted to. These are all your attempts to escape pain, distress, discomfort with the self. And no infant is uncomfortable with themselves. So that discomfort is a response to the parents' discomfort. And in the case of the most traumatized population, the parents' high level of dysfunction, which goes back to their own childhoods. So there's no one to blame. It's multi-generational, but that's how it's transmitted. It's not genetic. Alcoholism is not a genetic disease. Drug addiction is not a genetic disease. That's one of those myths that our society likes to hold on to. It runs in families, but not because of genes, but because of emotional patterns and behaviors that give rise to that same pain and that same desire to escape from the pain. So that's the first reason. The second reason why negative childhood experiences, particularly trauma, predisposed to addiction is because it actually shapes the brain in certain ways, so that the brain's reward chemicals, the circuitry that modulates those chemicals, doesn't develop as well in a traumatized child, nor do the circuits that regulate stress. So their way of regulating stress is to do something that soothes their pain temporarily. So when you're stressed, you're gonna drink a lot, eat a lot, go shopping, spend money you haven't got, do drugs. Those circuits again develop or don't in response to childhood experience. And the more supportive and security environment, the more optimally those circuits develop. Now you've got the reward and the pleasure and the happiness chemicals inside you, and they're available to you. But what happens if the environment doesn't promote or encourage that kind of development? Then you'll be seeking it from the outside. So addictions, whether physical or behavioral, are all about trying to seek something from the outside that you're not able to generate from within. And it all goes back to pain and loss and in the severe cases, trauma.
Okay, just a little bit about culture and trauma. Cultural background can determine how a family or an individual responds to trauma, and this could include family values and culture that can combine to determine what's considered appropriate responses to trauma and illnesses. Some cultures feel it's a sign of weakness to admit personal distress, and there may also be specific cultural customs in response to trauma. For example, not telling all the family members or not letting the children be involved in discussions, for example. Culture shapes the way individuals parent their children and how children experience their childhood. So, for example, behaviors that are thought to be abusive in one culture, such as corporal punishment or harsh verbal discipline, may be considered acceptable in another culture. Now, the Convention on the Rights of the Child in 1989 happened, and 44 countries subsequently outlawed corporal punishment, but it is still legal in the United States. And there may be differential exposure to adverse outcomes such as racial, ethnic discrimination, or differential access to protective measures like income, healthcare, education, police protection. And that may be determined by culture. And some cultures, such as African American and Native American cultures, have historical trauma that has impacted their culture. For example, indigenous cultures, the original inhabitants of a geographic area who've been displaced or marginalized by colonization, are found to have generally increased risk of discrimination, poverty, addiction, family violence, and poor health. But it's really important that we don't mistakenly conclude that these people who have been traumatized are less resilient than others. Commonly, the very opposite is true. People and groups who are subjected to chronic stressors or deprivations tend to be more resilient than others, but they also are more exposed to and less protected from traumatic stressors. So sometimes culture can be a buffer against trauma. Things like spirituality, traditional healing practices, finding a sense of meaning, and cultural rituals can also be very helpful. We know that ACEs are more common in BIPOC families, in children across all racial groups. Black and Hispanic children are exposed to more adversities than white children. The level of substance use, So this is a study at the bottom, showed 61% of Black children and 51% of Latinx children have experienced at least one adversity, compared with 40% of white children and only 23% of Asian children. So let's look now at how substance use disorders and trauma go hand in hand. And I think it's really important to note, and this is a study that happened in an urban primary care patient environment. And in this highly traumatized population, there were high levels of substance use disorder, which you see in the second line there, 39% with alcohol use, 34% with cocaine, 6% heroin and opiates, and 44.8% with marijuana. But the level of substance use, particularly cocaine, strongly correlated with the levels of childhood physical, sexual, emotional abuse, and PTSD. So substance use disorders are highly comorbid with post-traumatic stress disorders and other mood disorders. And this study shows that this, relationship between childhood trauma, substance use disorders, and PTSD. Okay, so I just want to talk to you about one case. We'll just go right into it then. This is Billy, who is the second of 5 children in a middle-class Black family. And he was very close to his father. He was bright, funny, loved to play pranks on his siblings. However, there was some adversity in his childhood. First of all, his mother experienced postpartum depression and then later experienced what would now be diagnosed probably as bipolar disorder. And then when Billy went to college, his dad, who had been his rock in life, died suddenly and unexpectedly of a massive heart attack. This really hit Billy hard, and he started experimenting with drugs and quickly found his drug of choice, heroin. So he continued to use heroin throughout most of his life and served over 10 years in the federal penitentiary with drug-related charges. And he was married. He had 3 biological children and 2 stepchildren. He did not spend much time with them because of his addiction. However, when he was in his late 40s, early 50s, he had almost died from kidney failure due to untreated high blood pressure and the effects of his opiate use disorder. He ended up getting a kidney transplant and subsequently had 2 other transplants. And during that time, he became very, very close to his grandchildren. And that was his way of making amends to his children. He was their grandchildren's caretaker, very beloved. They all called him Pawpaw. And Billy continued to stay off of heroin. However, within maybe 8 to 10 years before he passed, he started drinking very heavily. And over time, this had its own set of consequences. So this case just shows you that relationship between childhood adversity and, the development of substance use disorders. And we could even, go into a little bit about how his kids fared. They all are very productive citizens, good people, etc. He stayed married until his death. But his children also have some consequences. All of them have, severe obesity. I think most of the grandchildren have had to undergo gastric bypass surgery, weight loss surgery because of, their morbid obesity. So just to mention a little bit about Billy is that Billy was my brother. He and I were 13 months apart, and he was a very wonderful, big-hearted person, but the substance use disorder really hijacked his potential in life. So talking about substance use disorders and trauma in adolescence, if an adolescent has experienced sexual assault, they're 4.5 times more likely to abuse alcohol, 4 times more likely to abuse cannabis, 9 times more likely to have hard drug abuse or dependence. And if you add to that they have post-traumatic stress disorder, they're 4 times more likely than those without PTSD to abuse alcohol or have alcohol use disorder, 6 times more likely to have marijuana dependence, 9 times more likely to have other drug dependence. In a community sample of women, these were the instances of abuse. 60% had sexual abuse, 55% with physical, 46 emotional, 83 emotional neglect, and 59% physical neglect. So this slide is just emphasizing that relationship between post-traumatic stress disorder and substance use disorder. And for those those treatment centers that are not screening for trauma, not screening for ACEs, not screening for post-traumatic stress disorder, it's very hard to get traction in substance use disorder recovery without treating trauma and PTSD. You'd have poor outcomes, increased physical health problems, poor social functioning, higher suicide attempts, more legal problems, increased risk of violence, worse treatment adherence, and less improvement during treatment. So up to half of individuals with alcohol use disorders and PTSD also have co-occurring mental health issues. I think most of us know this, or they have polysubstance use disorders, and they also have chronic physical illnesses and chronic pain. Okay, let me just talk now and switch to talking about Mary, who is one of my patients with binge eating disorder. And she started being bullied in kindergarten for being bigger than everyone else. Her mother also was a binge eater, and when Mary was 8, her mom would send her to the store to get binge food for her mom. And she started then eating snacks in secret and hiding the wrappers. She had a very abusive stepfather who constantly called her fat and constantly focused on her body and her size. She continued to overeat and sneak food until high school when she started working, and then she would binge on fast food. She had a best friend who was also a binge eater, and they became binge buddies. And this continued until college when she started going to an ED group and was able to stop binging. She was married and in an abusive relationship with her husband. And just eventually they separated and so on. She grew up in a rough neighborhood. And I think part of her trauma was that she was biracial, white and African-American, and the neighborhood was mostly Hispanic or white. So she experienced a lot of anti-Black bullying. Her stepdad, as I mentioned, was abusive. He was an alcoholic, also had a substance use problem, and he was emotionally and physically abusive, cheated on the mom, and so on. Her biological father was not in her life. And when he was in her life, he was also emotionally abusive. He was a Vietnam vet and very disappointed about her weight, called her the Pillsbury Doughboy. Mother had a breakdown during middle school and so on. So she eventually came into my online program, the Anchor program, and we were able to work with her on first, body acceptance, and then second, work with her on healing from the trauma that she had experienced growing up. She's doing really well. She's worked with me for, I think, 3.5 years now, but she still struggles with accepting if she does lose weight. For example, her doctor put her on a diet because she developed diabetes, and she lost weight. And then the fears come up because, she had been harmed when she was at a smaller size. So her weight actually served as a protection for her. And that's the last piece that needs to change. So we know from the studies, even though the eating disorders were not part of the ACE study, we know from multiple studies that the vast majority of women and men with anorexia, bulimia, and binge eating disorder have a history of interpersonal trauma. And the amounts may vary, but the degree of those who reported sexual trauma were more likely to exhibit psychopathology than controls, including higher rates of both post-traumatic stress disorder and eating disorders. So they can be associated with all forms of trauma. It occurs in men, women with eating disorder, children, adults, everyone. Now, some people use their weight as a protection, as I mentioned with Mary. And then others try to disappear as a way of being unattractive. So women and men with trauma and PTSD have much higher rates of eating disorders than the general population. And this relationship may be mediated by emotional dysregulation. Remember the limbic brain. So there's also cross addiction. As eating disorders become more severe, the number of substances used may increase. Well, you can treat one and then the other pops up. In the old days, we used to say that it was use of stimulants and amphetamines to lose weight, but now it's all of the drugs and also alcohol. And women with either a substance use disorder or an eating disorder were 4 times more likely to develop the other disorder than the other women. Just to mention that attachment styles and sensitivity may affect sensitivity to media images, and insecure attachment is associated with the binging and restricting and negative body image, and may predispose to increased risk of relapse. The same pretty much goes for substance use disorders. So I want to just wind up here with what is the purpose of therapy. And I think from my perspective, therapy must address the changes that have occurred in the brain. They must heal the brain because we know that these changes in the brain affect a person's ability to function and to stay in recovery. So current, therapies target the limbic or cortical systems, but changing the brain requires repetitions to modify these nerve cell connections in the brain. I think I've told you about Mary, so I'll go on. So just a note on cultural resilience. I think it's really important to recognize that, as I mentioned earlier, people who are survivors of trauma often have very high levels of resilience. And I love this schematic that was put together by Martin Broken Leg and his colleagues. And he developed this circle of courage resilience model that he uses to train professionals worldwide. And it starts with significance, realizing that one matters to others creates enormous strength inside of that person. And this describes the Native American spirit of belonging. Competence, a capable human being can learn, solve problems, and develop talents and abilities. And this is the joy that comes from mastery. Power, this is not power wielded over others, but the ability to control one's emotions and set the course of one's destiny. And this is true independence. And finally, virtue. Ultimately, one cannot know that he or she is valued unless he or she is of value to others. And this is the spirit of generosity. So I think when we look at treating people with eating disorders and addictions or co-occurring ED and SUD, we want to really understand their childhood maltreatment, whether they have attachment issues, assess the developmental status of the brain, decide which therapies are important and how to combine them. How can you address food in a way that impacts the lower brain and the higher brain? Because you have people with eating disorders, they know they're not supposed to eat these foods, or they know they don't want to binge, and they can't convince themselves not to. So that's the higher brain fighting with the primitive brain and the emotional brain. And then teaching stress management skills and building a foundation for recovery. So I'm happy to take questions now if we have time. These are my books. If you're interested, I have a chapter in treating Black women with eating disorders, and then I'm the author of the other 2, as well as one of the first books on binge eating disorder.
Thank you so much, Dr. Ross. I'm going to begin to take some questions, but I wanted to mention a few things. For any persons that called in today via audio only, we ask that you send an email with your name and time of date of attendance so that we can ensure that you have credit if you are asking for any type of continuing educational credit for the webinar. And as a reminder, the slides will be sent out along with the evaluation at the end of the webinar. This recording will be available on the NC Training Center 2 weeks from today. I'll now start with our questions. Any unanswered questions will be sent to you via email 1 week from today with those responses. The first question reads, do the following conditions affect brain premature birth or any trauma at birth as a baby, such as heart surgery, baby stops breathing, difficult delivery?
Yeah, I mean, I think all of those have the potential to affect brain development, but they are a single incident. And so even if there is an effect, remember the baby's brain is very plastic, has plasticity. So they go from that traumatic incident to a loving, nurturing, safe, and secure home. Those changes can likely be reversed. Unless they're severe, like, oxygen deprivation or something like that.
Thank you so much, Dr. Ross. The next question reads, I work in addiction medicine at a large university medical center. Trauma/PTSD is barely assessed in our patients and never discussed in case discussion and rarely diagnosed. I find these patients cycle through rehab and substance use disorder programs over and over again for years, sometimes decades, without the PTSD ever being treated. How can I get my colleagues to assess for PTSD more thoroughly and give it more clinical attention and treatment?
Well, I've done a lot of grand rounds at university centers for that very reason. And I think education is the most important thing. So, and you can also start to screen yourself or include that in histories yourself and bring it up in your discussions of patients to help people start to become more aware. But I think having an expert come and speak to your group, or if you have an expert within your university, that's a start. It's at this point, the ACE study has been around for over 20 years. And it's really, almost malpractice not to take into account the effects of trauma. And you heard Dr. Gabor Mate say that all addiction has its roots in trauma. So not to address that it's really, it's a shame at this point that if that doesn't happen. I'm happy to come to your university or virtually and speak to your group. If you're interested, let me know.
Thank you so much, Dr. Ross. The next question reads, has there been any evidence of trauma in children born from reproductive treatment through IVF?
I don't know of any evidence. I haven't studied that, so I'm sorry, I can't answer that question really intelligently.
Thank you so much, Dr. Ross. The next question reads, is it possible to view the video separately and provide the name of the video presenter, the video that you showed during the presentation?
Yeah, then I just mentioned his name, Dr. Gabor, Gabor, Mate, Mate. You can view it on YouTube. So all you have to do is just Google Gabor Mate and addiction on YouTube. And I think the title of the video was The Roots of Addiction. So if you put in his name and then The Roots of Addiction, it should take you directly to that.
Thank you. The next question reads, using Billy's case as an example, does the external factors influence more in a person's functioning levels than the internal factors or attributes or abilities that a person has in life?
That's a great question. That's a, nature versus nurture question. In my brother's case, I think he definitely had a lot of internal factors. And remember, as being an African-American family, there's the historical trauma. And I know that my grandfather, who was extremely high functioning, was also a high functioning alcoholic. And then in my mother's generation, she had two brothers with alcohol use disorder. So, you have to look at the multi-generational aspect of trauma, as well as the individual person's personality and, et cetera. As I said to you, my brother had a very big heart, but that also meant he was super sensitive. He wasn't always able to screen out the things that affected him. And so often that led to him, numbing himself with drugs and alcohol.
Thank you. Thank you once again, Dr. Ross. The next question reads, regarding the MRI of the brain, does the brain behave compulsive, expecting being rewarded since conception?
I'm sorry, I didn't get that one.
So it says, regarding the MRI of the brain, does the brain behave compulsively, expecting being rewarded since conception?
Oh, I wouldn't call it compulsive. I think it's more of a natural system that we have that, for example, if you eat an ice cream cone and your brain gets a hit of dopamine, then you walk down the street 5 weeks later and you see a picture of an ice cream cone, your brain will also get a hit of dopamine, even if you haven't tasted it. I don't think that's compulsive. I think it's a natural instinct, kind of more of a survival instinct, that we get drawn more to things that create pleasure and reward for us, like sex, for example, and food. That's a survival part of our system, of our brain. So I don't think it's compulsive. I think it can become compulsive if it's overused. And so we know that people who have binge eating disorder or bulimia, that they may have, higher spikes in dopamine, or maybe more sensitive to those spikes. And that can then cause problems for them with cravings and inability to stop their binging behaviors. And the same thing goes for drugs and alcohol. We know that.
Wonderful. Thank you so much for that response as well. The next question reads, is there any research in the effectiveness of EMDR in treating eating disorders specifically related to past trauma? And what treatment approaches do you recommend?
Yeah, EMDR is now, and has been for some time, a very well accepted trauma treatment. When I worked in an inpatient facility at Sierra Tucson and then at the ranch in Tennessee, EMDR was a hallmark of treatment for our eating disorder patients with past trauma, most of them with, women with sexual abuse trauma or physical, emotional abuse, et cetera, all the things we've talked about. So EMDR is very, very effective, and there are many studies to show that. And the same in using it for treating trauma and substance use disorder patients. The other trauma therapies that I've personally experienced, somatic experiencing, also very effective, brain spotting. I'm going to forget some, I'm sure. Bessel van der Kolk has developed a trauma-informed yoga system that a number of yoga teachers have trained on. And he is high on that one because we know from stroke patients that repetitive movement helps to heal the brain, whether it be yoga or any kind of repetitive movement, exercise, running, biking, etc. But in the case of yoga, he makes a good case that because it is a mind, body, spirit practice, it helps even more. And so trauma-informed yoga is another trauma therapy, actually. So there's quite a few. Somatic experiencing and EMDR are probably the oldest, though.
Thank you once again, Dr. Ross, and I'll read this last question in the essence of time. I miss your discussion. Does the research indicate that people with more trauma abuse HX have more resilience, meaning strength for future trauma or abuse, or less?
I'm not sure I get that one. So is the question asking, if you have more trauma, do you tend to have more resilience?
Yeah, does the research indicate that people with more trauma/abuse have more resilience, meaning strength for future trauma or
Yeah.
abuse, or less?
Yeah, no, I mean, there is a personal component, for example, there are some people in families who just are born with more resilience. On a side note, resilience can be taught and resilience can be learned. But yes, for many people, trauma translates into higher levels of resilience. If you're a survivor, you have to have resilience because you've survived. I think, I can just look in my own family, and I can certainly say that as the oldest of 5, I probably am the most resilient in my family. But all of us who've experienced, the death of my dad and my mom's mental illness have more resilience than a lot of people we know. So, yeah, I think trauma it's kind of, diamonds made by pressure kind of thing. So, yeah, we've seen that over and over, that resilience can result from abuse and trauma.
Thank you so much, Dr. Ross. I want to thank you all once again for coming today, and for enjoying our talk and presenting these wonderful questions. Dr. Ross, did you have any last final thoughts that you wanted to share or comments?
No, I just encourage, I think on the first slide, you have my contact information. And if you have any other questions that come up, feel free to email me or send those to Lachelle, and she can email them to me. I really appreciate your showing up for this and, listening, and hopefully it's been helpful to illuminate some of your work and help you clinically with your clients.
Thank you all once again. And as a reminder, slides will be sent along with the evaluation following the webinar once we conclude. And any unanswered questions will be sent out via email to all attendees with responses 1 week from today. Thank you once again for your time.